Thank you. Good evening and welcome to tonight's webinar entitled Periocular Aesthetics Perspectives on Rejuvenation. I am Dr. Feliz Katrina Ranche and I will be moderating tonight with Dr. Charis Tanlapco. We are presently in this Zoom webinar and we are being streamed to the Philippine Network of Young Ophthalmologists YouTube channel. Sorry. Okay, so I was muted pala. So good evening, everyone. Hi, Ma'am Trina. I am excited about tonight because it's the first ever collaboration of the Philippine Network of Young Ophthalmologists with a subspecialty society. So because I'm a PSOPers member, so it's but natural that I chose PSOPers to be the first partner of the Philippine Network of Young Ophthalmologists. So before we start, we'd like to acknowledge and thank our support coming from the Philippine Academy of Ophthalmology. Thank you to the President, Dr. Margarita Latluna, and Dr. Donna Santiago, the Vice President of the Academy, and also a past President of PSOPers. So now, to formally welcome us to tonight's event, we shall hear from the President of the Philippine Society of Ophthalmic, Plastic, and Reconstructive Surgery, Dr. Charmaine Ang.
Okay, good evening, everyone. So welcome to the very first collaboration of PSOPers and the Young Ophthalmologists. I would just like to congratulate the person who made all this possible, Dr. Chai Tanlapco. She's the PAO's YO representative and also a board director of the PSOPers, and also her team of young ophthalmologists for a great job organizing this event. Thank you again to Dr. Marge Latluna, Dr. Donna Santiago, and the rest of the PAO Council and the Secretariat for allowing us to use the Zoom webinar to be able to stream this nationwide. So without further ado, let's just all sit back, relax, and enjoy this webinar. Thank you.
Thank you, Dr. Charmaine. So now let's get down to business. The first part of this lecture series will be about the surgical approach to periocular rejuvenation. You may write down your comments and questions in the chat box in the Zoom webinar or in the comment section of the YouTube channel. So our first speaker is a Green Archer. She had her Doctor of Medicine and Ophthalmology residency training at the De La Salle University Medical Center. And then she completed her fellowship in Ophthalmic, Plastic, and Reconstructive Surgery at the University of the Philippines, Philippine General Hospital. Right now, she is the Assistant Training Officer of De La Salle Department of Ophthalmology and is also an active consultant at the Asian Hospital and Medical Center, Las Piñas Doctors Hospital, and UniHealth Parañaque Hospital. She's, of course, an active member of the PSOPers. So, doctors, Dr. Catherine Vigo-Matic. Ma'am Cathy?
Hi, good evening, Chai. Good evening, Dr. Charmaine, Trina. Thank you for inviting me and congratulations, Chai, for this successful event.
Are you sharing na po? So while Ma'am Cathy is sharing, we have 116 attendees, 108 attendees. So Blackpink, hello Blackpink.
Hi.
Okay, there you go.
Daughters. Okay. Hi, good evening again. So we will start. The New York Times called them the Instagrams. Popular Instagram influencers, amazing women in their prime. So much can still be done when the spirit remains young. For some, they choose to look how they feel inside, to make them stride into years with more confidence. Good evening again, everyone. I am Dr. Catherine Vigo-Matic, and thank you for joining us this evening. It is inevitable that the physical body changes over time. Oftentimes, the periocular area shows the first noticeable signs of aging. To fully understand the aging dynamics, we should be familiar with the normal periocular orientations. Here are salient features. The eyebrows of the females are slightly arched, especially at the junction of the central and lateral thirds, and are slightly above the superior orbital rim. Males, on the other hand, have straight and thick brows that rest at the edge of the rim. The eyelashes are everted without touching the corneas. The upper lid covers 1 to 2 millimeters of the superior cornea, and objectively, we quantify this as the margin reflex distance. So here we measure the distance between the lid margin and the central light reflex. And normally, this value is 3 to 4 millimeters. The outer corner of the eye, or the lateral canthal angle, has a natural slant and is 1 millimeter higher than the inner corner. The lower eyelid sits tangential or just at the level of the inferior cornea, without showing any sclera. In oculoplasty, these structures, the forehead, eyebrows, and eyelids, are considered a single unit. Together, they make up the periocular area. They interact to provide first and foremost globe protection and aperture for vision. Moreover, they convey mood and emotions and provide the main aesthetic highlight of the face. So here's what happens with aging. Muscles and supporting tissues weaken and stretch, causing sagging of structures. So for one, the eyebrows droop, more often laterally, attributed to the relative lack of frontalis support at this area. The eyelid skin sag and appear as redundant folds called dermatochalasis. The weight of the drooping brow pushes on this, aggravating the folds. Weakening of the orbital septum leads to prolapse of fat pads, causing bags and festoons. Conversely, fat pads may also deflate, causing volume loss and deepening of the sulcus. The levator aponeurosis, which is in charge of lifting the upper lid, may also stretch or disinsert from its attachment, which is the tarsus. Consequently, the eyebrows droop, and this is called blepharoptosis. The lower lid sags as the canthal tendon stretches and becomes lax. It may rotate inward or outward. Finally, the skin thins out and loses elasticity, developing fine lines, wrinkles, and deep folds. It is very important to recognize all these changes since the structures make up a single aesthetic unit. So it is not advisable to isolate one and address its problem independently. If other structures are overlooked, surgery will be unsatisfactory. There are functional and aesthetic implications of periocular aging. For example, patients may complain of visual obstruction due to brow or lid ptosis, while others are mainly concerned with aesthetic rejuvenation. Non-surgical interventions like lasers, fillers, threads, chemical peels, neurotoxin injections are very excellent options, and we will learn more about all of these later from Dr. Vitas. However, for problems where these procedures won't suffice, or for longer lasting and more permanent enhancements, surgical interventions are considered. More than restoring a youthful appearance, periocular rejuvenation restores facial harmony, lifting, drooping, sagging structures, removing excess tissues, filling in lost volumes, with the goal of maintaining harmony among all periocular structures. Therefore, it is essential to do a thorough pre-op evaluation so that no structure is overlooked. Here are salient points in doing the pre-op exam. Palpate brow position relative to the rim. Recall that female brows are above the rim while male brows are just at the edge. Check for volume loss from fat atrophy, and these are hollow areas, for example, a deep sulcus or a tear trough. Look for bulging fat pads and lacrimal gland prolapse. Gentle pressure on the globe can prolapse them further. Rule out blepharoptosis by manually lifting sagging brows to accurately measure lid height using the MRDs. Check for lateral canthal laxity that cause lid malpositions. Normal lids should have a quick return on snapback test. The Bell's phenomenon should be tested, especially when ptosis surgery is contemplated. Pinch the redundant skin to estimate the amount to be removed. And if there is brow ptosis, you have to manually lift it to proper position first and to make sure that enough skin is pinched to avoid lag of thalamus. The natural lid crease depends on ethnicity and gender, and the surgical incision will create your new lid crease. So the incision will dictate your height and your contour. The patient's preference and surgeon's recommendation should be very clear during the pre-op planning. The lateral canthal shape and height should be noted. Check if it is 1 millimeter above the medial canthus or the inner corner as it should be, and check for rounding or loss of angulation. Lastly, the skin texture should not be overlooked. Patients should be informed of fine lines, furrows, wrinkles that cannot be addressed surgically. Also, the forehead furrows like these mask brow or lid ptosis as the frontalis muscle tries to compensate by lifting the brows. You always ask the patient to relax the frontalis to determine resting positions of the lids and the eyebrows. The most commonly done surgical procedure is the blepharoplasty or the removal of the redundant skin. Before deciding to do bleph alone, pre-op evaluation should have ruled out other problems. So this is a patient with upper lid dermatochalasis. The photo is shared by my mentor back in fellowship, Dr. Alex Tan. Thank you, Dr. Tan. Note that the brows and the upper lids are in normal position. And Dr. Tan did the traditional upper lid blepharoplasty for her. So here is his patient post-op. So how exactly is bleph done? So here's a very short time-lapse video from one of my surgeries showing a standard blepharoplasty procedure. Redundant skin is pinched and marked. You have to aim for symmetry in the resulting lid crease height and the amount of skin that will remain, not the skin that's removed. Lid crease incision is done for a concealed scar. The height of the lid crease is discussed with the patient pre-op. So here, the marked area is then excised. Some surgeons use the scalpel and some use electrocautery like this, or the more advanced RW or CO2 laser. What's important is to maintain good hemostasis and minimal tissue trauma. Extra caution should be taken to avoid over-excision of the skin, and the fat pads here are prolapsed and excised as needed. So skin is then closed with a cutting, non-absorbable suture. And for this one, we used nylon 6O. The scar is now the new eyelid crease. For those who desire natural looking appearance, the original or the natural crease is followed, like this one. And for a more Western or a deep set look, a crease higher than the existing one may be created. So Dr. Tan followed the natural lid crease of his patient. Next are the bags and the sagging skin on the lower lids. They make patients look haggard and tired or sometimes seem older than their ages. Here is one of my patients who wanted a rejuvenation. So transcutaneous lower lid blepharoplasty is ideal for her. So this approach is useful for cases with evident dermatochalasis, so for which loose skin has to be excised. So skin is incised inferior to the lash line. Fat pads are exposed and removed as in the upper blepharoplasty, and excess skin is pulled, excised, and redraped. Note that horizontal traction is preferred over vertical traction in the lower lid bleph when redraping the skin to prevent eyelid retraction. So here's my patient immediately post-op, and here she is, 1 year post-op. She just sent me this photo because she couldn't follow up anymore because of the pandemic. So there, for her, I did the lower lid transcutaneous blepharoplasty and bilateral upper lid blepharoplasty. On the other hand, this patient had predominance of lower lid fat and not much loose skin on the lower lids. Some redundant skin. There you see the bulging fat pads on the lower lids, and then skin redundancy on both upper lids. She is in her late 40s and she desired natural looking rejuvenation with minimal skin incisions. So, what's perfect for her is the transconjunctival blepharoplasty to sculpt the excessive lower lid fats. Its main advantage is the absence of a visible skin incision. So, here the fat pads are directly accessed through the inner aspect of the eyelids through the conjunctival incision below the tarsus. So for her, I did bilateral upper lid blepharoplasty and and bilateral transconjunctival lower lid blepharoplasty. Here she is. This is her. This is she 4 months post-op. The idea of rejuvenation is frequently associated with blepharoplasty alone. Some patients think that removing their eye bags is enough, but most of the time it is. But sometimes there are other concomitant issues. Unfortunately, when these are overlooked, the results will be suboptimal. Let us look at this next patient. The upper lid is clearly redundant. However, a thorough examination will also reveal that the brows are drooping and the position is below the bony rim, especially laterally. Brow ptosis is one of the frequently overlooked aspects when doing blepharoplasties. It gives a melancholic or worried expression. The brow also weighs down on the lid skin, worsening its redundancy. In fact, there are cases when dermatochalasis improve with brow lifts alone, as the surgically lifted brow pulls up on the folded skin. Conversely, doing blepharoplasty alone on a patient with significant brow ptosis will not improve the haggard look. Choice of brow lift techniques depend on patient's age, gender, surgeon preference, and even the forehead anatomy. Invasive techniques like the coronal and the trichophytic lifts make hairline incisions from which undermining proceeds inferiorly towards the brow area. Skin is pulled up, excised, and redraped at the hairline. Though highly invasive, it gives the strongest permanent lift to the brow and to the whole forehead. Disadvantage of this is the long recovery period and the possibility of permanent forehead numbness. However, patients with high or receding hairlines are not good candidates for this. So, therefore, the next option for this is the mid forehead approach, and it is ideal for those with deep forehead furrows since the elliptical incisions are placed along these lines. As in the corona lifts, the skin is dissected inferiorly towards the brow, pulled up, and redraped, lifting the lower half of the forehead and the eyebrow. So this is the patient post-op. Aside from the brow lift, I also did upper lid blepharoplasty for him. Direct browplasty is a good option for lateral brow ptosis, as or patients with thick and heavy brows who need a strong lift without being too invasive. The incision is placed along the skin at the outer aspect of the brow. And similar to a blepharoplasty surgery, the marked ellipse of skin is excised and redraped to pull the brow up. So here's the patient. We did bilateral direct browplasty for him and also bilateral upper lid blepharoplasty. Internal browpexy is ideal when an upper lid blepharoplasty is also contemplated. They are done simultaneously as the subbrow area here is accessed through the same lid crease incision, and from here dissection is carried out superior to the superior rim, wherein the subbrow fat are directly um, anchored to the periosteum of the rim, are about 10 to 12 millimeters above the rim. So this lift is relatively weaker, hence it's not recommended for men with heavy brows. For those who will undergo blepharoplasty with moderate lateral brow ptosis and prefers the least amount of skin incision as possible, so this is for them. So this is our patient. We did bilateral internal browpexy with bilateral upper lid blepharoplasty. The most advanced and the least invasive of all is the endoscopic lift. Tiny elliptical incisions are concealed on the scalp behind the hairline. Camera-guided subgaleal or subperiosteal dissection is carried on inferiorly towards the brow area, lysing skin muscle connections, after which the hairline, forehead, and brow are pulled up. The skin is secured to the periosteum by suturing or by tacking using a dissolvable brow appliance called the endotine. Brow lift techniques vary and are tailored for each patient. Surgeon preferences vary also. Some do not even opt to touch the brows. But what's important is to discuss it with the patient, as this is an important aspect in rejuvenation. Another condition that should not be overlooked is blepharoptosis. If not addressed, patients will persistently complain of visual obstruction and rejuvenation will not be optimal. This is my patient. She consulted because of obstructed vision, lid heaviness, and a permanently haggard appearance. And on evaluation, her entire brow position was below the superior rim, weighing down on the upper lid and aggravating the dermatochalasis. As I manually lifted her brows to anatomic position, the skin redundancy was reduced, but then another finding became apparent, and this is the MRD1 for the right is 1 millimeter only, while the MRD2 for the left is 2 millimeters, and this confirms ptosis. So let's see what happens if brow lift alone is done on this patient. The brows are repositioned here, as you can see. So first I did the direct browplasty for her because her brow skin was relatively thicker. So and the entire brow was below the rim. So a direct browplasty was performed. And then if you can see that the MRDs remain the same. The most common cause of this acquired ptosis in aging is the stretching or the disinsertion of the levator aponeurosis muscle from its eyelid attachment. So for this patient, together with the brow lift and the blepharoplasty, I also did levator advancement, wherein the disinserted aponeurosis was reattached to its original attachment at the tarsal plate. For so after doing bilateral direct brow lift, blepharoplasty, and ptosis levator advancement. So this is my patient 4 months post-op. For mild ptosis, there is a less invasive procedure with no need for skin incision, and this is the Façonella Servat Müllerectomy. The Müller's muscle is a minor lid elevator, and shortening it will give 1 to 2 millimeters of eyelid lift. The incision is hidden beneath the upper lid, and therefore skin may be avoided if there's no dermatochalasis. However, it may also be done in conjunction with a BLEF, as some studies show good results when doing the combination of both of muellerectomy with blepharoptosis instead of doing the levator advancement. Just like what I did with this patient, he had left-sided browtosis and mild blepharoptosis on the left also, and bilateral dermatochalasis. So on the upper lid. So I did direct browplasty for the left and muellerectomy for the lidosis, also on the left, and bilateral blepharoplasty. Lower lid position should be routinely evaluated. Canthal tendons suspend the lower lids on the bony rim, keeping them stable. They stretch with age, more often seen laterally. With this, lower lid position changes. So it may descend, seen as this space between the cornea and the lid, or it may rotate outwards or inwards. Lower lid laxity should be simultaneously addressed to optimize surgical rejuvenation. The most common procedure to correct canthal laxity is the lateral tarsal strip, wherein the lateral tarsus, which is anatomically connected to the canthal tendons, is stripped and sutured directly to the periosteum of the lateral orbital rim. So this is the lateral tarsus, and it is directly sutured to the lateral orbital rim, periosteum, at a more superior location. Now, the canthopexy is a minimally invasive procedure that gives an instant lift and instant rejuvenation to sagging outer corners or droopy lower lids. It has become a sought after trend even in younger females, as it has been popularized as the cat's eye surgery by Hollywood stars like Kim Kardashian and Ariana Grande. So um, it can be performed through a minimal skin incision, either at the lateral canthal area or if there is a simultaneous upper lid or lower lid bleph. So from this incision, the suture is passed on to engage the lower lid canthal tendon and to be sutured on to the lateral rim periosteum at a much higher position, creating the cat's eye or restoring the almond shape of the eye. Current trends change how surgeons approach the aging periocular area. So there has been a shift of focus from removing excess to restoring losses. Volume loss happens with fat atrophy and aging changes in the bony structure. So let's see what happens when an underlying volume loss is not addressed in a standard rejuvenation surgery. This patient with ptosis and dermatochalasis underwent blepharoplasty and ptosis surgery. So there is significant improvement in the appearance, as you can see on the right. The lids are not ptotic anymore. But then you take note of the deep superior sulcus, and this is the hollow area below the rim. So removal of the redundant skin consequently exposed a volume deficient sulcus, revealing a more a socket that is hollower than how it was pre-op. So this might make us consider the likelihood of addressing the drooping brow by making this hollow space fuller. So because of cases like this, the interest of some surgeons has shifted from volume replacement as they propose that fat deflation is a major factor in facial aging mechanism. For example, a drooping brow or brow descent may be a consequence of fat atrophy of the subbrow and eyelid fat pads. or this lower lid bag made apparent as the nasojuggle or the tear trough hollows due to the nasal fat pad atrophy. So you see that the orbital rim also became apparent with the atrophy of the nasal fat pads. This trend has led surgeons to focus on volume replacement as an important aspect of rejuvenation. So hyaluronic acid fillers, popularly known as the dermal fillers, are most commonly used to restore fullness in the hollow areas. For the surgical alternatives, so we use the dermis fat grafts, the micro fat grafts, and the more recent nano fat grafting, wherein the patient's own fat coming from the thigh or the abdomen is harvested through liposuction, and then a micro cannula is inserted into the volume deficient areas of the face. So the fat that was aspirated through liposuction is centrifuged in this machine that you see here. And then you see a, a liquid solution of fat, tiny fat particles, and these particles are directly injected into the volume deficient areas of the face. So a less complicated surgical procedure is the fat transposition. So this can be done simultaneously with a blepharoplasty. So instead of excising the prolapsed fat pads, they are released, maintaining an intact pedicle, and then pulled towards the lost volume and sutured onto the areas with deficient volume. So in this case, the deficient area is the hollow area at the orbitoglobular groove. So numerous studies compared the use of fat grafts and filler injections in periocular volume replacement. So fat graft is your own body tissue, hence the body does not recognize this as foreign. It's also more permanent and it is ideal in pan-facial volume loss. However, it is not an office procedure and it involves another surgical site. Therefore, there is a surgical downtime. Also, the results may be unpredictable and not like the dermal fillers, which can be sculpted with precision in specific areas. So here are the pros and cons. Later, Dr. Gail will discuss further about the dermal fillers. Lastly, the skin texture problems like pigmentations, wrinkles, fine lines should be discussed with the patients pre-op to avoid unrealistic expectations. They have to be informed that there might be a need for adjunct procedures like lasers, Botox fillers, chemical peels post-op. So it is important to work with a dermatologist to give the most optimal management. Some oculoplastic surgeons are equipped with CO2 lasers and they can perform this simultaneously with a blepharoplasty. For example, Dr. Christine Santos, she's one of our PSOPers colleagues. She shared her photos of her patient with me. These photos are posted with permission. Dr. Santos can perform CO2 laser skin treatment after her surgeries to address skin texture problems. So this is her patient whose concern is the multiple lid folds. And Dr. Christine did blepharoplasty to remove the redundant skin. To optimize the smoothening of her lid skin, she also did CO2 skin laser treatment simultaneously or after her blepharoplasty. CO2 lasers are ablative lasers that resurface the skin by removing the outer layer. And you will learn more about this and other non-surgical treatments of the skin in a while. Part of the complete rejuvenation plan is to advise patients if there is a need for non-surgical interventions post-op. So in my practice, I refer my post-op patients to a dermatologist when there is a need. And clearly, an in-depth understanding of the form and function of these dynamic structures is essential for optimal aesthetic enhancement of the eye area. So in a few minutes, we will all hear from Dr. Vitas to enlighten us more about the non-surgical procedures. And I know that we are all very excited for this. So this is the end of my lecture. Thank you very much for listening.
Thank you so much, Kathy, for that comprehensive rundown of all the surgical options available. A reminder for our audience, if you have questions or comments for Dr. Matic, kindly post your questions in the Zoom chat or in the YouTube comment section.
So the second part of our lecture should also be interesting for us because it will be about the non-surgical approach to periocular rejuvenation. And plus our guest lecturer is a dermatologist. So if Ma'am Kathy is a green archer, our second speaker is a blue eagle because she had her pre-med at the in Ateneo. So, but she completed her Doctor of Medicine degree at the University of the East, and then she had her dermatology residency training at the Skin and Cancer Foundation. She's a board certified dermatologist who enjoys teaching and giving lectures here and abroad. So her special interests include aesthetic and procedural dermatology, such as cosmeceuticals, injectables, lasers, and energy based devices. So, doctors, Dr. Irene Gail Robredo Vitas.
Thanks, Chai. Good evening, everyone. Thank you very much for that kind introduction. I am honored to have been invited to this activity. Hold on. There. And I hope everyone is safe and well. I'd like to congratulate Dr. Matic for a very comprehensive lecture. All the more now, I believe that our specialties go hand in hand in making sure that the eye area is, receives the attention it deserves inside and out. So, okay, now I will be discussing periocular rejuvenation, the non-surgical approach. Hold on. Okay. So I have no conflicts of interest to disclose for this evening's lecture, and my lecture outline would be as follows. Why are our eyes important? Facial aging, the periorbital and the periocular area, common concerns and treatment options, and some take-home points. So they say that the eyes speak all the words that the mouth cannot. And they're also referred to as the windows to our soul. According to a study by Adam Anderson, the eyes evolved over 500 million years ago for the purposes of sight, but now are essential for interpersonal insight. The eyes dominate emotional communication, and we can determine a person's emotions by analyzing the expression in their eyes. In their study, narrowed eyes were consistently associated with emotions related to discrimination, such as disgust and suspicion. In contrast, people linked open eyes with emotions related to sensitivity like fear and awe. There are 6 common facial expressions according to Anderson and his co-author Daniel H. Lee: that of sadness, disgust, anger, joy, fear, and surprise. And their studies found that the eyes offered a more robust indication of emotions compared to other parts of the face, like the nose and the mouth. In aesthetics, the periorbital area is often the first to show signs of aging, especially when neglected. The skin is thinner, more delicate, and susceptible to structural and volumetric changes around it. These not only impact the appearance, but also the perceived emotion, energy, and health status of an individual. Rejuvenating the area will improve the aesthetic balance of the face, hence, procedures in this area are often requested. Fortunately, there are several treatment options, both surgical and non-surgical, and modalities available. So now let's go to facial aging. Facial aging is a complex, multifactorial process that is actually three-dimensional. It is dynamic and it is generally not the same for everyone. All people age differently as a result of changes occurring in all 5 facial anatomic layers: the skeletal layer, the muscular layer, including the ligaments, the subcutaneous layer, and the skin. So in the young, the periocular region, as explained by Dr. Matic earlier, is defined by fullness of the periorbital area, taut skin with little or no excess or laxity, minimal pigmentation and lines and wrinkles, and appropriate brow height and shape. But as we age, beginning in the third decade, Some may start to notice loss of definition of the palpebral lines and redundancy of the skin in the upper eyelids. And by the fourth decade, lateral canthal lines become more pronounced, as well as the lower eyelid folds. And these gradually progress as one ages, making one appear tired and sometimes even sad. So, facial skin aging specifically is caused by both intrinsic and extrinsic factors. This would include your UV radiation exposure, lifestyle and habits, work status, mental stress, gravity, and even conditions that affect the body and affect our appearance during aging. All of the layers of the skin undergo age related changes, and in this region, it is thin and closely attached to the underlying muscle. In the tear trough area, this results in a grayish blue hue related to the underlying vasculature. Hyperpigmentation and telangiectasias may appear due to sun damage, and enlargement of certain glands occurs, such as in syringomas, and growths like skin tags appear. In the dermis, collagen and elastin become loose and less organized, such that fine lines and wrinkles start to form. Underneath the skin are the fat pads, where the aging signs are attributable to the weakening of the orbital septum, descent, loss of volume, and pseudoherniation of fat pads, which can cause hooding or a heavy lid on top and eye bags at the bottom. After the fat pads are the periorbital muscles, which include the frontalis that elevates the brow, and the depressor muscles, which include the orbital portion of the orbicularis oculi muscle, the corrugator, the procerus, and the depressor supercilii muscle. In the glabella, the corrugator muscles cause vertical lines, while the procerus cause horizontal lines. I cannot show you right now because I have toxins. The orbicularis oculi muscles are the ones that lead to crow's feet formation. The facial skeleton is believed to grow and expand with aging. Recent studies also show that certain portions of the facial bones undergo resorption with aging and can result in changes like hollowness of the infraorbital area. Apart from aging, aesthetic concerns may be due to several other causes, which include your genetics, repeated facial expression, your lifestyle, such as sun exposure, stress, and even poor diet, history of trauma or injury, and other ocular or systemic conditions that may affect periocular morphology. And to add to that, as aesthetic practitioners, we also have to put into consideration gender differences and ethnicities when choosing and administering procedures because standards, outcomes, expectations, side effects differ between and among these populations. Since periocular aging is often multifactorial, treatments should ideally involve a combination of modalities and procedures. Um, and knowledge of anatomy and the changes that happen are important for the appropriate selection and matching of ideal candidates to treatments. Therefore, periocular rejuvenation should be individualized to patient need and expectation and physician comfort and experience. Let us now talk about common concerns in the periocular region. Often, the person's eyes are the first feature you notice or look at when meeting someone new. Changes in the eyes affect their overall appearance. We can have fine lines, which can be due to dryness of the skin or loss of moisture, or even decrease in collagen and elastin. Dark circles, which can be due to factors such as UV radiation exposure, genetics, or more visible blood vessels underneath because of loss of fat or collagen in the skin above them. Puffiness can be from allergies, not getting enough sleep, consumption of food high in sodium, drinking too much alcohol, or simply due to gravity after oversleeping. And other conditions and concerns like dynamic and static lines and hollowness or loss of volume. In my clinic, the following are the most common concerns patients come to me for treatment. So you have pigmentation, loss of volume, tear trough hollowing, poor skin quality, fine lines, dynamic wrinkles, puffiness, skin laxity, eye bags, hooding, and static wrinkles. Patient assessment is very important. Prior to any treatment or procedure, a thorough medical and ocular history should be obtained, including medications, allergies, and existing conditions. Aesthetic procedures done in the past, such as neuromodulators, soft tissue filler injections, laser light therapies, and even surgery should be discussed, as well as their feedback from them and possible complications, if any. Adequate and complete physical exam is a must, paying close attention to skin type and quality, degree of laxity, volume loss, volume descent, periorbital hollowing, and skeletonization, pseudoherniation of fat, dynamic and static wrinkles, and positioning of the brows. And goal setting is also equally important. Talk to your patients about their treatment goals, desires, preferences, and expectations. Discuss all the potential benefits, risks, and complications, and the temporary nature of some treatments like your botulinum toxin injections, and all the options or alternatives available. And always obtain a written consent. Now we go to treatment options. I remember very clearly how my grandmother was telling me that we are lucky because nowadays there are so many available treatments to slow down and even reverse the signs of aging. And because the aging process involves many different changes, in many patients, a combination treatment is often necessary. The important question is when, what, and how to combine different aesthetic interventions safely and effectively. When it comes to skin rejuvenation, I always do a combination approach, never monotherapy. And I always consider the individual as a whole, taking into account the different layers of the skin and how it affects the entire face to create harmony and balance. I divide them into four categories: topical treatment, surface procedures, or those that are found in the superficial part of the skin, or those that I do in the superficial part of the skin, injectables, and lasers and energy based devices. Under topical treatment would be cleansers, serum, creams, balms, and oils. Before starting patients on any treatment, I usually reinforce and encourage them to stick to a basic skin regimen to rejuvenate and prepare the skin for what is about to come. This includes proper cleansing, which prevents buildup of dead skin cells, to remove oil, dirt, and bacteria that can accumulate and later on lead to breakouts. Regular exfoliation, which helps remove dead skin cells to encourage production of new ones and allow for better penetration of the products you put on your skin. Nourishing and repairing the skin with moisturizers containing pro-collagen such as your vitamin A, C, antioxidants, and peptides. And of course, sun protection by using broad spectrum SPF 30 plus water resistant sunscreens, applying enough amount and reapplying as needed. And of course, it's important to know which ingredients to look for based on what you're trying to treat. Once the signs of aging start to appear, fine lines can be treated with retinoids, growth factors, and peptides. Pigmentation with lightening ingredients like your hydroquinone, your arbutin, your kojic acid, and vitamin C. Puffiness with creams containing caffeine, green tea, and coffee berry polyphenols. And for general maintenance, ingredients like your ceramides, hyaluronic acid, and vitamin E. The one question I often get asked is, are eye creams necessary? Can I use a regular face moisturizer in my eye area? So unless you're already experiencing problems specific to the eye area, there's really no need for an eye cream. Other moisturizing creams, for as long as they do not contain harsh ingredients that are too strong or may irritate the eye area, are actually sufficient to nourish and protect it. You can use your face moisturizer for the skin around your eyes. It's important to take care of this sensitive part of the face, but not necessarily with eye creams right away. Eye creams are specifically formulated to address the needs of the eye area, and these creams usually contain active ingredients that target the eye area issues, have reduced concentrations of active ingredients. For example, your retinols in the eye area will usually contain 0.1% instead of the one for the face, which would go about 0.5 to even 1%. May have thicker consistency or have more oils compared to usual creams addressing other areas of the body. And usually they come in very small containers in 5 to 15 ml containers. Next, we go to surface procedures such as your electrocautery, microdermabrasion, and chemical peel. So the eye area is a common location for benign skin tumors and growths, such as your skin tags, your seborrheic keratosis, which can be removed by electrocautery. Other lesions include milia, which can be removed with a simple incision and drainage. Some tumors, like your syringomas, I don't do electrocautery on them. Instead, I use a special machine, a monopolar radio frequency machine that uses an insulated needle to kill and burn the gland at the root. And we also have peeling procedures, which are often done to remove the top layer of the skin, resulting in smoother, younger looking skin. And in this area, I also do mechanical exfoliation using microdermabrasion or chemical exfoliation using superficial chemical peels like your glycolic acid 20%. So when treating patients, prevention should always be the first option, especially in those under 30. But sometimes genetics, your habits, and your age can actually work against you. And when you reach the point where topical treatments simply aren't enough, there are a number of non surgical options out there, starting with injectables like your mesotherapy, neuromodulators, and soft tissue fillers that can be done. So let's start with mesotherapy. In 1952, Dr. Michael Pistor, a French doctor, developed the technique of mesotherapy. It is a technique wherein ingredients such as hyaluronic acid, enzymes, and sometimes even botulinum toxin are injected into the skin. In the eye area, I do it to rejuvenate and tighten loose skin, lighten pigmentation, as well as remove excess fat. I do it either manually or mechanically. So in this video, I am using a machine with very fine needles to deliver hyaluronic acid with botulinum toxin A into the dermis. Now we go to neuromodulators, or also called botulinum toxin A. So I use botulinum toxin A to prevent and improve the overactivity of the periocular muscles that contribute to crow's feet and puffiness of the lower eyelid and to lift the brows. It is a safe and effective treatment provided it is done correctly by an experienced practitioner with a good knowledge of anatomy and how the product works. So some common side effects can include brow and eyelid ptosis when the toxin is inadvertently injected or diffuses to the wrong muscles, even double vision or blurred vision, and sometimes headache and nausea. Treatment outcomes treatment outcome varies widely between providers and is influenced by the number of units used, treatment or injection points, and the patient's response to botulinum toxin A. So this is a before and after photo of my husband because he was the only one I could use. So as you can see, his crow's feet improved significantly. And now we go to the next injectable that I use, which is hyaluronic acid fillers. So I use hyaluronic acid fillers to address volume loss from decreased hyaluronic acid production, collagen degeneration, and facial bone reabsorption. The goal when doing this is to restore lost facial volume and also to balance and to have balance and to get an ideal facial ratio correlated with his physical attractiveness. So the type and composition of hyaluronic acid filler matters when injecting into the periorbital area. I personally choose one that is cohesive with a lower HA concentration. Using one with higher cohesivity ensures better dermal integration, which also results in a lower likelihood of migration and a greater predictability over time. One thing about correcting the tear trough area, though, is I always recommend to first support the lower eyelid, possibly by restoring the cheek volume, reducing periocular muscle activity with neuromodulators, and promoting collagen formation with energy-based devices before I actually treat the tear trough area. The most common complications include bruising and swelling or edema. And uncommon ones include filler migration and the Tyndall effect, which are usually related to technique. And unwanted complications are vascular occlusion and blindness, which can be minimized and avoided with a good knowledge of anatomy, a lot of experience, and a sound injection technique. So these are before and after photos of soft fissure injections in the tear trough area. And here are two more. Now we go to lasers and energy-based devices. This would include the ultrasound, radio frequency, and lasers and light devices. So this is just a photo showing the differences in depth of penetration of lasers versus radio frequency and ultrasound. So we want to achieve a certain temperature to be able to provide good outcome for our patient. So pigment lasers is something that I like to use in the periorbital area. you have your quality switch or Q switch lasers, which are very effective in lightening pigmentation in the skin. For example, post-inflammatory hyperpigmentation in the periorbital area, such as in this patient in the video. I also use it in removing benign epidermal lesions like freckles and ephilids, like in this patient. And also dermal lesions like your nevus of Ota. Now we go to non-ablative laser surfacing. Sorry. Non-ablative lasers were developed for the improvement of photoaging. Usually, they are ideal when you don't want a lot of side effects or complications, especially when doing these treatments in patients with darker skin types. If you want better patient comfort and tolerance and minimal to no downtime when you compare it to the ablative treatments. The goal when doing non-ablative laser surfacing is to stimulate collagen in the dermis without causing injury to the epidermis. In my clinic, I use a quasi-long pulse and a Q-switch Nd:YAG 1064 nanometer lasers as my non-ablative laser surfacing tools. And ablative fractional resurfacing, it works by thermally ablating or causing microscopic columns of epidermal and dermal tissue in regularly spaced arrays over a fraction of the skin surface, leaving surrounding normal and skin tissues intact. It is an intermediate approach with an overall increased efficacy compared to non-ablative resurfacing and safety, especially in darker skin type. Usually, the ablative fractional resurfacing lasers have faster recovery versus your fully ablative resurfacing procedures, but usually comes with downtime compared to your non-ablative laser resurfacing. In my clinic, I use an erbium YAG, 2940 nanometers, and CO2 lasers. So next we go to microfocused ultrasound. Microfocused ultrasound machines delivers energy at precise depths, reaching the temperature of 60 to 70 degrees Celsius, which is the temperature required to cause tissue to coagulate and collagen to denature. So the coagulated tissues are surrounded by healthy skin tissues or healthy tissues that stimulate the wound healing process and neocollagenesis. So in the photos, you would see different depths or targets depending on what you want to achieve or what you want to reach in your patient's skin. So this is how it looks done on porcine skin. So you can see the shots are delivered in equal spaces from each other and with sparing of the epidermis. And we go to radio frequency, which is a treatment that delivers heat energy to the dermis, heating it up to 40 to 50 degrees Celsius to stimulate collagen remodeling and production. Studies show that keeping a temperature of 42 to 45 degrees Celsius for a few minutes causes your body to release heat shock proteins that stimulate it to create new collagen fibers. So in my clinic, I use a combination of my bipolar radiofrequency, monopolar radiofrequency administered via insulated needles, and microneedling RF, all of which I use to rejuvenate the eye area. So now for our take-home points. They say that the best outcomes depend on using the appropriate tools and making sure that they are used correctly. Now, when do I refer my patients for surgery? Two things: patient issues and patient desires and preferences. A patient with significant pseudoherniation of fat, deep infraorbital groove, or significant midfacial volume loss will definitely benefit more from surgical intervention if he or she wants to see dramatic results. A non-surgical approach, in this case, may only improve the concerns minimally. It's up to the physician ultimately to provide the patient with the appropriate insight. Because as we all know, some patients don't want to undergo surgery and want to try first non-invasive procedures. But then again, later on, when they don't see anything significant, they would opt to have surgery instead. Younger individuals like these two will usually do well with non-surgical interventions, as well as these two. So you can probably do botulinum toxin injections, yung soft filler injections. Whereas most individuals, such as these two handsome gentlemen, would probably benefit more from surgery. Also, these two. However, age doesn't guarantee the need for surgical intervention. This handsome gentleman would probably do well with just CO2 laser surfacing, botulinum toxin injections, and maybe even some non-ablative laser surfacing. Also, this very beautiful older woman in this photo. Whereas younger individuals with issues like these may benefit more from surgery. So, we certainly do not want to raise too many eyebrows when rejuvenating the eye area. One tip is to take good photos before and emphasizing existing skin conditions like scars and facial asymmetry, and to compare it with even better after photos. I have had patients whom I forgot to point out existing asymmetry, and after any skin rejuvenating and aesthetic procedure, they become more attentive to their features, and sometimes they didn't notice before that they had asymmetry, and they would blame it on you. Let us not be um and sorry, and most definitely we don't want our patients frozen in time with one look and one kind of reaction. We don't want them to look the same when they're sad, when they're happy, when they're afraid, when they're scared. And we must also remember not to be overly critical of our flaws, especially in the eye area, because some of them are actually our features that make us different and attractive. When my patients point out these characteristics, I tell them to observe their children or their nephews or their nieces. Many of them have fine lines, even hooding, puffiness, and even hollowing. Certain things that we might think as signs of aging, which are actually not. Our goal is not to prevent aging, but to age as gracefully as possible because we will all grow old and look older. But we should always make our patients' expectations reasonable and attainable and the results sustainable. So, our goal is also to educate them on how to properly care for their eyes. Aesthetic defects cannot be prevented when they are associated with genetic and hereditary causes or linked to aging. However, measures can be taken to avoid accelerating degenerative skin processes such as wrinkle formation and marks. And we have to make sure to remember the following: sun protection by doing sun avoidance, using sunscreens and protective eyewear, healthy lifestyle such as a balanced diet, adequate restful sleep, and regular exercise, healthy habits like not smoking, drinking alcoholic beverages in moderation, being gentle when putting on products and removing them on our eye area, and having regular skin and eye checks and visits to a dermatologist and ophthalmologist. So, our goal is to rejuvenate the area without taking away its purpose, to show life and character, to communicate, and convey our emotions. So, with that, I thank you all for listening.
Thank you so much, Dr. Vitas. We will now have a short open forum. So if anyone has questions, you may type it in the Zoom chat or in the comment section of the YouTube channel. Again, we would like to thank the Philippine Academy of Ophthalmology. We'd like to acknowledge the presence of Dr. Adona Santiago, Vice President of the Academy. Thank you for helping us with this webinar. If maybe I'll field the first question for both Dr. Vitas and Dr. Matic. So, for example, a patient has dermatochalasis and poor skin quality and wants to have blepharoplasty and also non-invasive treatment. So, what's the ideal time for an ophthalmologist to refer to a dermatologist? So, is it necessary to refer pre-op for pre-op planning? Or if post-op lang kailangan, how long after the surgery? Is there any value to referring in the first 2 weeks, like early post-op period? Or do you want to see the patient after 2 to 3 months when all the sutures are out and it's fully recovered already?
Okay, so
Yeah.
yeah. For me in my practice, no. First of all, it depends on the severity because sometimes patients come to me and then they desire rejuvenation. So for patients with mild skin changes, most of the time they feel that just like what I mentioned earlier, no, most patients their idea of rejuvenation is blepharoplasty or removal of the skin. But then when you take a look at them, when you examine them, you see something else. And there really are times when there's no need for surgery, just like the picture of Dr. Vitas earlier, no, the elder female with her her structures are in the normal anatomic position. So what you need is what they need sometimes are just derma options, the derma treatments. And then if indeed they need surgery, like for example blepharoplasty. So if the problem is moderate to severe enough, so I do the surgery first, but then during pre-op planning, I prime the patient. I point out all the, like everything that I said in the lecture, all those aspects. I point it out to the patients just so that they won't have unrealistic expectations. Like also like what Dr. Arvita said, no, so it's very important. And I take lots of pictures kasi nga their expectations. And in contrast to what she said, after blepharoplasty, sometimes a patient would say, why is my skin still wrinkly or there's still fine lines? So if you fail to prime them with those things, they will not be satisfied despite the result of your surgery. So, and if after I do surgery, usually after 3 months, after the removing sutures and all, and they have already they have already recovered, that's when you see the final position of everything, the final position of the lids. That's when I refer to a dermatologist, especially if the skin texture and hollows and all those things are still and are still problems.
And
Me
for the
naman,
artist, yes.
uh, I like referring to surgeons, especially when my patients have problematic upper eyelid, because there's really not much you can do in terms of dermatology in that area, and it's really a bothersome, I guess, issue for them, especially the holding. But normally, what I would do is I would, of course, like what I said earlier, prepare them first, prepare the skin, and do everything I can. And then I refer to surgery. I refer for surgery because I think that I always tell them that for a definitive, for a definitive outcome and a more significant outcome, it's really surgery. Even for the lower area, for eye bags, there's really not much you can do in terms of lasers, injections, fillers. In fact, if when I inject filler in that area, when the patient insists, mas pumapangit ba? It actually looks worse. So, um, for very pronounced eye bags, hooding, and really dermatocalacia, I really refer to surgery.
Thank you.
Thank you.
Uh,
So we have a question. Did that answer the question? Huh? I think it did.
yes, yes.
So we have a question. So thank you, Dr. Alex Tan, for a question. So do you have any experience using PDO threads for the periocular area? So for any of you?
I don't.
I I don't have any. I haven't tried. Maybe the other PSOPers members.
Yeah, if we have
Yeah,
Gail,
if there are
yeah,
any PSOPers members with experience using PDO threads, kindly type also your feedback in the chat so we can read it to others. I'll take the next question na lang from Dr. Waraktan. This is for Dr. Vitas. How do you approach dark circles in young patients? Dark circles around the eyes in young patients? Like us.
like us.
Like us.
Well, actually, Doc, that's actually my problem. I have dark under eye circles, and in order to properly address it, you have to first identify the cause. Normally, dark under eye circles can be caused by number one, post-inflammatory hyperpigmentation. So, in individuals with history of allergic rhinitis who like to rub their eyes, nagkakaroon there comes a time wherein you develop post-inflammatory hyperpigmentation. So for that issue, I usually recommend creams that have lightening ingredients to improve the pigmentation. If your dark or pigmentation is due to thinning of the skin and which makes your the vasculature underneath visible, then I do injection of low concentration hyaluronic acid that's very cohesive to just sort of give space between your vasculature and your skin, so it becomes less dark. And then another cause would be heredity. So there are certain individuals, for example, Indians, they really have dark periorbital area, and you have to determine if it's really caused by something that they do, something that they did, or if it's really just genetic. I find that in those individuals with dark circles due to genetics, lasers work well, and normally after 2 to 4 sessions of the Q switch and the pigment laser, you would see around 60 to 80% improvement.
Thank you, Dr. Vitas. I think that's our last question, unless there's a further question on YouTube. While we're
That's
waiting, sorry, Chai.
No, I think we're
The
good.
last question. Thank you very much, Dr. Vitas and Dr. Matic, for answering our questions. Before we end, I'd like to share some announcements. So I'd like to invite everyone to the first roundtable discussion of the Peace Hoppers. This will be on Wednesday, March 31 next week at 6:30 p.m. We will be featuring cases from Cebu Velas General Hospital, Ilocos Training and Regional Medical Center, Western Visayas Medical Center, and we will have Peace Hoppers reactors, Doctors Armida Soler, Marco Tumalad, and Honey Lenteo. Do we have additional? Maybe we can have short picture taking with the panelists. Kindly turn on your videos. Sorry, there's another question, Hapal.
Last question.
Yeah,
Oh,
Chai,
take
can
it,
you?
take it, Antrina. Ikaw na lang, Antrina? Okay, sige, I'll take it. So, good evening. About nevus of Otta, what age is the start of treatment? Thank you. So, I think this is for Dr. Vitas. No? Gail, I think you're...
Yeah, sorry. So for nevus of Vota, there's really no age wherein you can start, but it's for me it's more of the procedure is quite painful. So I don't think that anyone younger than maybe 15 or 16 will be able to tolerate the pain, and it's kind of hard to explain it to a young patient na okay, I'm going to put anesthesia, you're going to feel this way. So at least in my practice, I do it on patients who are 18 and above, who can sign the consent form for themselves and can understand, the possible consequences of undergoing a laser treatment.
Okay. Thank you, Dr. Terry Lynn Lopez, for that nice question.
So we have feedback
So-
from Dr. De Leon. So in another group of cosmetic surgeons, they had seen patients who had threads placed, and those patients had difficulty in closing the eyes. Thank you, Dr. De Leon. Maybe we'll have the short picture taking, and then I'll have another announcement after. So may we ask Dr. Sharmi to turn on your video so we can take a quick screenshot. Shai, okay ba? Ikaw na.
Ay, ako na ba? Okay.
Sorry.
Okay, 1, 2, 3, game. Okay, 1, 2, 3, game. Okay.
Thank you. So another announcement, let me just share my screen. So for the Peace Hoppers members in the audience, these are our April activities. On April 8, we will have our general membership meeting. And on April 15, our first fellows paper presentation for the year. So now I'd like to call on Shai for the closing remarks.
Okay, so I think our topic for tonight was quite interesting because the techniques, machines, and even the solutions to keeping the periocular area looking young keep on changing, and we need to constantly have to update ourselves about it. So thank you to our guest speakers. Thank you, Ma'am Kathy. Thank you, Gail, for agreeing to talk tonight. And then thank you to the Philippine Academy of Ophthalmology, to the PAO admin. I believe that we have non-PAO members as viewers. So special thanks to the PISOPers and our YO families, Dr. Elaine Omania for our poster and virtual background, to Drs. Paul Shoponko and Camille Sabala for being our ever-reliable master streamers, and to Ma'am Joanne and the PAO admin, so for the technical assistance. So while webinars are good, I still believe that learning face-to-face together is still better again. And so thank you, everyone. Please stay safe and good night. Yeah. Thank you.
Thank you.
Good night.
Good night.
Good night po.